Well, welcome to the committee today. Must be something important we're doing today with all these people here. Okay. We have an informational hearing today on the topic of HMOs and et cetera. And I appreciate the interest. This is a very important topic. I'd say it's controversial, parts of it. I think some matters of it are delicate. Just take that as it is. But the point of today is not to embarrass anybody or castigate anybody or anything like that. We're not going to be questioning people's motives or personalities. We're going to ask a lot of questions. And I would request that the witnesses kind of hold to that, and that'll be a productive thing. Some people asked about public testimony. We are not having public testimony today for the simple reason there is no bill in front of us. This is an informational hearing to gather information, and there'll be a time for public testimony later when actually a bill arises, probably starting in a reform committee, and whatever that form that bill takes, then people could react to that, and there'll be ample time, I'm sure the chair assures me, for that. So what we are, the two chairs up here, and he can speak for himself, but we feel a duty to explore topics that come our way. However, some are very simple, some are very complicated and controversial. That would be this one. And so there'll be a lot of time for members to ask questions. So the format we're going to be, do you want to say something first? Sure. Okay.
I want to thank everybody for taking the time and attention to be here because, as Representative Abler pointed out, this is an extremely important issue. I would point out, too, this is not something that just suddenly came up. I think some people have that perception. We have, in fact, and I'm sure members of both sides of the aisle who are sitting here at the table from both committees will acknowledge, we've been talking about transparency and where the money is spent in a variety of government programs and health and human services programs in particular in all the time that I've been in this legislature. So we have been talking about where's the money going. Some people have described it as the black box. Others have asked about HMO transparency or whether the department or administration should be looking at this more closely under both administrations. So this has been coming for quite a while. Some new information has come to light more recently that we felt required us as representatives of Minnesotans to have an informational hearing, to find out more about this and find out if in fact there are things that either need to be corrected or modified in state government or in fact if there's any wrongdoing going on. We need to know about that on behalf of our constituents. But this is not a witch hunt, and we are trying to deal with this constructively and respectfully, and yet at the same time, I think try to get at some important facts. So, I want to thank everybody who's participating in the hearing today, and the committee members, and my co-chair, and my wife too for loaning me today on Valentine's Day. So.
And Mr. Feinwalks, you can come to the table and get set up if you like. Then I have a couple more things to say. Welcome Senator Nino, who's here, and I don't know who else is in the audience from the Senate or other members. Anyway, I hope there's room for everybody to sit. Yeah, and if there's other members in the audience from House or Senate, they're welcome to sit at the table with us too. I think we have ample seats, but that way it makes more room for other people who don't get to sit at the table. We're going to hear 3 half-hour presentations. From 3 different groups, Mr. Feinwalks, the department, and then the plans. And I believe in that order. I think that makes the most sense. And so I'd rather hold questions till the end. There'll be an entire hearing time available. We'll take a break somewhere in the middle when it makes sense, and then Chair Gavel will have the gavel to do that second half. I did just for people's information. There's a lot of numbers get thrown around. The amount of money spent in medical assistance managed care in 12 was $3.3 billion, state and federal, and $3.6 billion in 2013. So it's about $6.9 billion for the biennium. So everybody has these numbers. I just read them off the forecast for you. So went to 3, now it's 4. Well, kind of. You're around 3.2 down to 3, and you're running 3.6 up to 4. Anyway, we just want to have we want good facts, we want good data. And that's, I think, all I have. Mr. Feinwachs, welcome to the committee, and introduce yourself, and I think you have a presentation for us.
Chairman Abler, Chairman Gavel, thank you. My name is David Feinwachs. I'm a resident of the city of St. Paul, and I'm here today representing no group or interest in particular. I want to begin my comments by saying this. What I'm about to say is, I think, the most important thing that I'm going to say, and if you remember nothing else that is said by me today, I would ask you to remember this. Our Department of Human Services has almost 7,000 employees. Minnesota's health plans have many thousands of employees. None of this is about any of them. These people work hard. They do important work. They try to facilitate the provision of health care services. They go to work every day to support their families and make sure that medical claims are processed and bills get paid and that duplication and error is ferreted out and dealt with. And 99.99% of these people have nothing to do with any of this and are a credit to the health care system and really should be acknowledged as that. And I have not a single thing to say about them except to thank them for their commitment. Having said that, what I want to talk to you today is about process and our system and certain aspects of our system that we are all responsible for and that we need to look at and evaluate. The first slide, which is in the PowerPoint presentation, which is on the monitors and which you can see, I've recently been involved in some litigation, which is irrelevant to this issue, but did give me access to some things. And in the litigation, one of the things that I allege I heard was on August 13, I was a participant in a conference call involving a DHS employee where the statement was made, if you can't keep a secret, you have to leave the room, but we've been adjusting the reserve amount for state-only funded programs, making it essentially zero, and increasing the amount for PMAP federal programs, blending the rate, and returning it to the insurers. And now, when I heard this, I believe this to be impermissible. I believe that if indeed this is occurring, it is improper and problematic. As part of my litigation process, I had the opportunity to take the deposition of the employee that I heard make this statement. And the second slide that you see here is the cover sheet of that deposition. The next page is the employee, Karen Peed, answering the question directly, did you say this? And Ms. Peed did not recall making this statement. She acknowledged it may have been possible, but she didn't recall. I also had the opportunity to take the deposition of a man named Matthew Anderson, who was a former colleague and today works still at the Minnesota Hospital Association. Mr. Anderson was present at the call, and in his deposition, you'll see that Mr. Anderson says that he, and I quote, I don't know if that was her exact words, but there was part of the call where she was describing a DHS process that she didn't want us to tell or, disclose widely. And then Mr. Anderson goes on to say, what I understood her to say was that programs outside a federal match, that the state was decreasing the amount that it calculated or anticipated health plans would have as a reserve or margin down to zero, and using PMAP rates to leverage those higher, so in the end the plans are made whole and the state leverages more federal money. Mr. Anderson goes on to say she did not indicate that the money was returned to the plans. Mr. Anderson's recollection is fairly close to my recollection, and then leaves us with the first important issue, are we in fact doing this? I also had the opportunity to take the deposition of Ms. Nancy Feldman, who, as many of you know, is the CEO of UCare. Ms. Feldman made a statement in response to a memorandum that had been written about why these programs can't be looked at in isolation, and I believe this is a true statement. Because the way we look at our products is total bottom line, the state products. The products all intertwine. It's very difficult to pull them apart and look at the bottom line. I believe the federal regulations require that we do, in fact, pull them apart and that they not intertwine. I may be incorrect about this, but I believe some separate accounting is part of the federal regulatory scheme. The next slide that I am showing you is a letter dated November 10, 2003, which is a letter that was received by then DHS Commissioner Kevin Goodnow from the Office of Inspector General from the United States Department of Health and Human Services. And this letter dealt with an audit of our Department of Human Services and some of the calculations. And the part that I've highlighted for you reads in pertinent part, and this is the OIG speaking. We noted the state agency included administrative costs and a profit factor for its state-funded prepaid general assistance medical care, general assistance program, in the actuarial rate calculations for the program, meaning the Medicaid program, in 2001 and 2002. This was contrary to federal cost principles and misstated the actuarial calculations available for future rate setting. Now, to their credit, my understanding is that DHS did not implement this once it was pointed out to them by the Office of Inspector General and did not use this sort of actuarial misrepresentation and, in fact, abandoned it. Recently, in 2010, we saw a number of bills introduced that had a common theme. The common theme of this legislation was auditing, the use of generally accepted accounting principles, the imposition of medical loss ratios to better track and account for the money, and forfeitures or givebacks, if you will, if these bills were to pass, of the state's vendors in the event they were found to have retained too much of the money that was given to them for programmatic purposes. They would then refund the impermissible excess, according to the proposed legislation, back to the state of Minnesota. The current slide is a fiscal note which analyzes those kinds of proposals, and what is interesting about it is the end, in particular the last sentence, because the fiscal note says, if a health plan doesn't meet, in this case, the 93.5%, but the number's irrelevant, loss ratio, and pays a penalty, the cost of paying the penalty will be included in the health plan's experience in subsequent years and may result in higher DHS capitation rates. This is important for two reasons. I believe the word may is included here because I'm not sure DHS knows what's in those capitation rates. And more importantly, if the statement is a true statement and the plans recover their costs and expenses in the subsequent year, these are not actually risk contracts, but more in the nature of reimbursement contracts, which then asks the important question, why are we reserving in large quantities against what appears to be non-existent risk? The next two emails that are on the screen, these are a couple of emails that occurred on the evening of March 15. And they're important only in that they set a backdrop. They are emails between the commissioner and one of her assistants discussing the extraordinary event of UCare returning to the state some $30 million. The $30 million give back was quite remarkable. I don't think anyone in recent memory had ever seen anything like this. You'll see at the bottom the first email from Mr. Pollack, who at the time was with DHS, says, unfortunately, I think this really good news is likely to generate far more questions from legislators about our PMAP contracts and adequacy of health plan reserves. And the responsive email from the commissioner states, in order to have a good chance of keeping the money, it must be characterized as a donation. If a refund, the feds clearly get half, which is true. Can you work with Scott on redrafting? And also, I thought we were going to handle this through phone calls. Now, the importance of these emails is that on the 15th, on the evening of the 15th, there is not a doubt in my mind that people thought that UCare's Act was, in fact, a donation, a gift. And these emails, I think, reflect that thinking. The next day, UCare distributed the following letter to a handful of select legislators. This letter reads in pertinent part, historically DHS rates set for general assistance medical care resulted in health plan losses. Now that is no shocking news. Every medical provider you will ever talk to will tell you that the GAMC program was underfunded, ill-conceived, and a horrible program for healthcare providers. There's no shocking news there. It goes on to say, which were offset by higher medical assistance payments. And I think most providers would be surprised by that because they don't think they've received any higher medical assistance payments to offset the GAMC program. The letter also says when GAMC moved out of managed care in mid-year 2010, when Governor Pawlenty dismantled the program and did away with it, medical assistance rates were not lowered to reflect this overpayment. And the word overpayment here is key, because I know that Chair Gottwald said, and I agree with him, and this is the only time I will deviate, I am not here to cast blame, except in this case. The blame falls with the legislature. It falls with all of you, because you received $30 million accompanied by a letter that referred to overpayment. Yet no one asked the question, how could such an overpayment occur? No one asked the question, who else might owe the refund of an overpayment? No one asked the question, is the amount of the overpayment being given back sufficient? And no one asked the question, what steps will we take in the future to assure that whatever caused this overpayment isn't repeated in the future? These, I would respectfully submit to you, are the questions of a prudent fiduciary, and I think many people were disappointed and dismayed that these inquiries did not occur. In 2008, our legislative auditor did a report, and this report was a very well done document, 175 pages in length, and I suspect that only persons such as myself who enjoy reading this kind of thing delved into it in any detail. But nevertheless, it is quite an excellent, if not analysis, compendium of observations about our programs and some interesting things. And I'm going to revisit that briefly and share some of it with you. The legislative auditor can observe that our managed care capitation rates for these public programs are relatively high compared with other states, that our spending per enrollee grew faster than the national rate in recent years. Nevertheless, all of you have heard the bitter complaining from providers that they've not seen increases and that their payment hasn't changed or is woefully inadequate. This stands in stark contrast to these facts observed by the legislative auditor. The auditor also observed a very important thing, and that is, in recent years, health plans haven't reported aggregate losses from public programs. If you talk to providers, and I don't care who the providers are, hospitals, doctors, chiropractors, podiatrists, dentists, all of these providers will report to you that they lose on these programs individually and they lose on these programs in the aggregate. Yet the auditor observes that the plans do not report losses in recent years in the aggregate. Now, what on earth could account for this? Going back to Karen Pede's statement really becomes the Rosetta Stone. It's this statement which gives us the ability to understand and explain some of the observations which were made. When the legislative auditor conducted this report, made this inquiry and published this document, they didn't know this. Now, armed with that information, this would put some of these observations in a whole new light.
Mr. Feinwalch, you're just about halfway.
Thank you, sir.
Yeah.
I'm going to skip over some of the rest of the slides from the legislative auditor's report. This one, of course, says that the health department relies on the Commerce Department. The Commerce Department concerns itself with the wealth of health plans, and DHS doesn't collect detailed information on administrative costs regarding these programs. That's true. Even in 2008, the legislative auditor noted that there appear to be no actuarial standards of practice for this function. 2 years later, in 2010, the General Accountability Office said exactly the same thing in a published report that was critical of the federal government's oversight of these programs. The American Academy of Actuaries last January 2011 wrote a letter which contained this statement on page 6. And this is extremely important because this says that the state's actuary is not required to look for false or intentionally misleading data. They're not required to develop compilations to search for this kind of data, and they're not required to audit the data. From a policy perspective, you need to ask two questions. One, what exactly does the actuary do in these circumstances? And two, who does these things? Because it appears that no one does these things. Shortly after I took Ms. Peed's deposition, Ms. Peed left her position as the head of the Medicaid Managed Care for DHS and appears to have been reassigned. We have been pushing for a little over a year to find out if it has been permissible that the state's consulting actuary also has been allowed to consult with the state's vendors. Now, let me be perfectly clear about this. There is nothing to suggest that this consultation occurred. I don't know if the state's actuary consulted with the state's vendors, but DHS has recently told us that until now, such consultation has been possible. It has been allowable. Until the 2012 contract, the state's actuary would not have been prohibited from consulting with the state's vendors. The next few slides are a presentation which UCARE gave to a handful of select legislators, and I want to just deal with a couple of them. The first one is this, dealing with encounter data. As you all know, encounter data, and I know you, Chair Gottwald, have tried to obtain this kind of data for going on 3 years. Encounter data is the kind of data that talks about who got what kind of health care services. According to the slide prepared by UCARE, it says, encounter data can be reconciled to health plan financial statements, but will not tie because of accrual accounting rules. This means, by definition, we can never adequately track this money. If true, this is unacceptable. The next slide I want to draw your attention to is slide 26, which says at the bottom, state budget pressures sometimes influence capitation rates based on factors outside the scope of the Medicaid program. The Medicaid program is a program which is 50% funded by the federal government. By definition, there are no factors outside the scope of the Medicaid program which influence the rates, which are certified to the federal government as capitation for the program. The money can't be used to backfill other needs. The money can't be used to subsidize things that don't qualify for federal money. This statement is problematic. Now, the one explanation, in fairness, for this statement would be perhaps there are years when the state didn't just have the money to put up and get all the federal matching funds. But, of course, that's not the case. Year after year after year, the cost of the Medicaid program has increased. The state has put up more and more money every year, and the amount of federal match has always increased. So that explanation also does not appear to be viable here. According to UCARE, and this is absolutely true, insurance companies establish the need for risk reserve by looking at asset underwriting, credit, and business risk. I ask you, members of the committee, what is the asset underwriting, credit, and business risk of a scheme in which everyone recovers all of their costs plus an increase in the subsequent year? This, by the way, a number of people have been told that the calculation of insurance risk is an art form, not a science. This is what I will call an amusing slide. This is actually how insurance risk reserve is calculated. It is a problem in differential calculus. There is nothing artistic, and for that matter, nothing amusing, because I took differential calculus, about these equations or this slide. It is a scientific, precise process. This is one of the rate certification actuary letters from the state's consulting actuary, Milliman. It's important for a couple of reasons, because if you look at it, it says the capitation rates for this program are determined on a quarterly basis by blending, and that's the word Ms. Peed used, blending demographic rates which do not vary by managed care organizations. So the demographic rates, they are what they are. It doesn't matter who insures you, and that makes sense. And risk-adjusted rates which do vary, which asks the question, how are the risk-adjusted rates calculated, and why are they different, and how do these things come about? Milliman goes on in the center of the letter to disclaim, saying that the letter is only for DHS and no one else should or must rely on it. And, of course, on the second page, as the American Academy of Actuaries has suggested, they say they don't audit or verify this. They're just dealing with what they were given. And this leads us to an extremely important issue. Who sets and certifies the Medicaid rate in the state of Minnesota to the federal government? We've been asking this question for a number of years. The health plans say DHS does it. DHS says the state's actuary does it. The state's actuary says that DHS and the health plans do it. Someone must do it, and someone must be accountable for having done it. We cannot have a system where everybody points fingers at someone else and says, it's not my job. It has to be someone's job. The last series of slides are basically a series of emails that were obtained during the course of litigation that talk about legislative proposals. And they're only significant because of their response. This is a slide from the Council of Health Plans that talked about a piece of legislation that would have required audits and limitation on administrative expense. And it says it would require the plans to have to refund federal matching dollars, and DHS would have to do that too. Why? The question that must be asked is why? This is a slide that talks about me, apparently, and says that I had convinced then Senator Linda Berglund that the elimination of GAMC would cause a windfall for the plans. The fascinating thing is the slide says that when Karen Peed learned of this, she said that DHS would have to pay the plans back for any assessment. They would have to build it back into the rates. Again, the question arises, why? Why on earth would something like that occur? This is an email from I believe, Julie Bruner to the CEO of Health Partners and the CEO of UCare, talking about a conversation with Karen Peed from DHS. And Ms. Peed is reporting to them that a retired DHS employee had been interviewed by an attorney and asked about health plan or the Medicaid rate setting and contracting. And many people were upset about this. And, in fact, I was the root cause of this inquiry. What's interesting here is Ms. Peed was and is a public employee. If she had a concern about this line of inquiry, why wasn't this email addressed to the commissioner or her superior or any of the other people employed at DHS? Why is it addressed to the Council of Health Plans? This is an email which shows in the section, it's an email that was sent by the CEO of Health Partners while on vacation in Glacier Park, having learned that the retired DHS employee had been asked how the program works, and the email says, we need to connect with board members on this one. It is really bad. How really bad is it to ask a retired employee how the program works or how it worked when he was involved in running it? The next email talks about these being serious allegations. The next one talks about these are serious and allegations of illegality. And I apologize for the scan, it's cut off, but that's what that word says, illegality on the part of the plans. These people are talking to each other. There is no external voice. No one suggested illegality. This is an email from someone at Medica talking about a hospital system that asks them to walk through the Medicaid rate setting process. And it says, then they asked if we could walk them through the process. I'm sure you'll agree this statement goes beyond a reference to a black box and indirectly accuses DHS of not complying with federal laws. No one said that. Where does that come from? This is an email which I think, if anything, is the one that is most easily understandable and the one which cries out for what's required here. This is an email from the council to its own staff talking about the preparation of a rebuttal to the materials that I have prepared in my allegations. This talks about Pat Garrity, who at the time was the head of Blue Cross, and it says we need to get some information. What's interesting here is you'll notice it says in all cap letters, just ask for the Medicaid spending in all categories, just the Medicaid spending, and then it says, we need it to add up to 100% somehow. And I think that pretty much describes the problem. Because for all of us, for the taxpayers, for the legislature, for everyone in this room today, we need it to add up to 100% somehow. And the fact that it doesn't cries out for an independent audit and some reconciliation of these programs. The next email discusses me and describes the fact that I'm on a mission and that the plans can only hope that my rhetoric is so extreme that I marginalize myself. I would hope that the plans could only hope that they could refute this, that they could explain this, that they could show what it is that has been overlooked, misunderstood, or mischaracterized. Because if this is their only hope, this is a long shot. This is an email from Julie Bruner to an attorney who's with a firm that represents UCare. It's kind of a Christmas email. It talks about the holiday season and good cheer and good wine. It also talks about a video that I made, which some of you have seen, a half-hour boring video. And it says, I'm not sure how he thinks he's going to prove collusion between DHS and the plans on PMAP, but he clearly insinuates it in his video. I insinuated nothing in my video other than no one knows how this works and no one can appear to figure it out or account for it. And so this is an unusual email. It also goes on to say it's unclear what the ask is unless it's for the plans to disclose what they pay, and it ends with, don't think that's going to happen. The final email is an odd email. It involves me personally, and it is, from my perspective, bizarre. It is an email from Julie Bruner at the Minnesota Council of Health Plans to the gentleman who fired me. And it says, I hope you put some restrictions on what he can say in his severance agreement. And I assume the misspelling there refers to MHA. I'm here to tell you today, for the record, that there were ample restrictions in that agreement on what I could say in both of those agreements. I'm also here to tell you that I took neither one of them. The final email also tells the story. It's an email from the Council of Health Plans to Commissioner Jessen before she was the commissioner, telling her, giving her a link to the video and saying this is the Fine Walks effort that got him dismissed from the Hospital Association, but is getting some media attention. At the time, Channel 5 was covering it, I believe. It goes on to say, I'm concerned it not get traction with the Dayton camp without a chance to discuss the real facts involved in the story. And members, that's where we are. We need to know what are the real facts in the story. If we are engaged in the activity that Ms. Peed described in her statement, which I heard and which Ms. Anderson, which Mr. Anderson heard, we have to ask, is this a legitimate activity? Is it permissible? Is it a gray area? Is it unlawful? And if it is, in its kindest characterization, a gray area, let us say for the sake of argument, do we want the people's business done in a gray area? Is this the reason for the secrecy that seems to surround the operation of these programs for these many years? Because no one wanted to talk about this or draw any attention to it? Well, it's out there now. So if we're not doing it, that's fine. If we're doing it, we need to address it. And going forward, we need to address, are we going to allow the people's business, even outsourced business, to be conducted in secrecy? Should the public not know where its money goes? Almost 20 years ago, scholars were writing articles saying it's a bad idea to outsource these programs. If you outsource these programs, you're going to lose your most valuable resource, data and information about how they work. You're going to lose information about the cost of health care, who's providing it, who's paid for it, what works, what doesn't work. And 20 years ago, it was predicted we'd end up with a black box. I respectfully submit to you, we have that black box. It is a disadvantage to every consumer who has an HSA, who would desperately benefit from information the state might have to offer about the real costs of health care. It is a disadvantage to policymakers such as yourselves who are being asked to trust blindly and, more importantly, fly blindly in the crafting of policies, and it is a disadvantage to every medical provider in this state who is in essence compelled by what we call Rule 101 to be forced to participate in these programs no matter what, yet they cannot see how these programs work, and they are left to wonder whether the financial losses they incur benefit the patients, the state of Minnesota, or simply profit some intermediary broker. As always, I appreciate the opportunity to speak. Thank you, and I would be happy to answer any questions at the appropriate time.
Thank you, and I appreciate your being right on time with your presentation. The department can come down now. And so it's my intention, if anybody came in late, members, we're going to take all the testimony, and then when that's completed, then we'll call the group up, and there'll be something of a panel, and we'll have a dialogue for a period of hours about this. And there'll be a break in the middle sometime. Commissioner, welcome. Mr. Lights, welcome. You have a half hour, and the time is yours to spend as you wish.
Thank you so much, Mr. Chair. Mr. Chair, members of the committee, I'm Lucinda Jessen. I'm Commissioner of the Department of Human Services. Happy Valentine's Day. I'm glad I'm not the only one wearing a little red. And just thank you for the opportunity to talk about some of these things, to talk about the Department of Human Services' role in contracting with managed care plans to provide health care services in both our MA and our Minnesota Care programs. Before I jump into the substance of my testimony today, I just want to make it clear what I'm going to cover, what Assistant Commissioner Lights is going to address today, and hopefully between the two of us we can answer questions you have, if not during our testimony, then afterwards. So in my testimony, I'm going to discuss the situation that Commissioner Lights and I found the healthcare area of the department's work when I started a year and a month ago today as Commissioner. I'll talk about some of the actions that we've taken based upon our assessment, as well as what we plan to do in the future and where we think this should go. And Assistant Commissioner Lights is going to talk about the work in more detail that we've done on competitive bidding, the status of the audits that are being done by the Department of Commerce under the Governor's executive order, and he's going to also update you on some other reporting and data analysis pieces. So if I could start, and bear with me a little bit here, because I want to just start, kind of take a step back and talk about the general structure of our state's public health care programs today, but I also want to talk a little bit about where I think they're headed in the future. Because I think while we have this conversation, and don't worry, I'm going to get to it, let's do it thinking about where, not just where we are and where we've been, but where we want to go. As you all know, Minnesota made a decision a number of years ago that many of the enrollees in our public health insurance programs would be enrolled in managed care. A primary reason, as I understand it, and you all were here before I was, but as I understand it, it was to ensure adequate access to our services for all of our medical assistance enrollees. And this has been largely successful on this measure. You do not hear widespread concerns about access to services under medical assistance. I know that's not true for every enrollee or every service. I'm thinking of some dental services here. But overall, I think that is true. And that is something that managed care has helped us to facilitate in Minnesota, and we should acknowledge that. And like other states where they allow for-profit health plans to participate in Medicaid, Minnesota does not. And I think this has helped our state manage costs and ensure the taxpayers get more value for their dollars. And finally, I think managed care provides more care coordination than in our fragmented fee-for-service system. Not always as much as I would hope for, but more. So collectively, for many of our enrollees, this has been a good fit, and they're able to receive the services they need. For other individuals, such as many of our disabled individuals, they have historically found our fee-for-service system to be one that gave them a much broader choice of providers, something that they greatly valued and was much better for them. But frankly, coming in, I see problems with both of these systems. You know, under our purely unfettered fee-for-service system, it can lead to bad incentives. The incentives are do more tests, more visits, lack of emphasis on incentives for high-quality outcomes, lack of care coordination, though we're trying to address that through our medical home progress. And frankly, our rates are so low that we do have access problems in parts of our state. And, as we'll address a little more later, historically on the managed care front, we have not done enough to either contain costs in these programs or to incentivize better care in many of our products. So what I want to make clear is that, as we see with both systems, neither is perfect. They both carry advantages and disadvantages. And while we're here today to mostly talk on the managed care side about how we can better manage our costs and their services in those contracts, I think we do need to start by saying fixing that alone really is not enough. That we really, and what we are trying to do, in addition to the work we're doing on managed care and our fee-for-service systems in the department, is really try and create a third way. This is an approach where we contract directly with providers to provide care, where the incentives are better aligned with better care, lower costs for specific populations. So under this approach, which we are pushing, providers will be given more flexibility to innovate and deliver care that, in a way that they know providers are closest to it, they know are going to get results. In the past, when providers created innovations that saved money, had better outcomes, often they were penalized because those savings accrued to health plans or employers. So under what I'm calling our third way, we want providers to share in savings that they create through innovations. We want to provide more direct incentives for high-quality, low-cost care. That's why we put out, as many of you know, a request for proposals last summer, and we're really delighted to receive 9 proposals to participate in this demonstration project. These providers are from all regions of our states, rural, urban, large, small, and I think this offers a real promising pathway to better care and lower costs for the people we serve. One of these projects was with Hennepin County that we recently agreed to, where they are agreeing to coordinate all their social service delivery, not just health care, in an attempt to achieve better outcomes amongst the hard-to-serve early expansion population. So historically, while I think the state has been behind the curve, behind the private sector in this kind of care, we are now trying to assume more of a leadership role and hope to move forward with this new care model. So thanks for bearing with me. But I do want to say that is the direction where I think we're going. But we can't get there overnight. These are demonstration projects. So in the meantime, we have to deal with the 2 programs we have, and particularly today, talk about dealing with our managed care plans. So let me say where we were, I think, when I started as commissioner. Now, I want to just give a little context here. When I came into the Department of Human Services, it's not like I found that everything was dire. There's a lot of great work going on at the department. Last fall, as many of you know, we received an award. Minnesota was recognized as being the #1 state in the country for delivering home and community-based services. I mean, that's an amazing thing, a tribute to our providers and advocates, to many of you. And I didn't say to myself, oh, wow, that happened because I've been Commissioner of Human Services for 10 months. I know that was the work of many of our the providers and advocates, I said it, and you, but also for hard-working employees of the department and the leadership, frankly, of the department over the past decade. So I just want to be clear that when I'm talking about things I wanted to change, there were many things I think which are a real tribute to our employees and to previous commissioners. But one of the 2 things I thought we most needed to change, and change quickly, became when I became commissioner, and which was also a concern with the governor, were a number of issues with state contracting for managed care plans. I didn't come into this just as a totally blank slate. I remember back when I was Assistant Attorney General for the state of Minnesota back in the mid-1990s. One of the things I did was I worked for the state employee health plan, and I helped negotiate some of their contracts. But I also, in another part of my job as Assistant Attorney General, I did some work for DHS. And one of the things that struck me even then, decades ago, was we were doing things with our state employee insurance plan that were innovative and creative, and we weren't doing it on the PMAP side. So it was something, I think, because of that, and I tried to draw attention to it, but not very successfully, that I kind of followed this across the years after I left state service in 1998. I remember even a few years ago, I was moderating a discussion about things that in the private sector they were doing. I remember there were folks from Fairview and Medica there talking about some innovative payment structures. So instead of just doing fee-for-service or traditional, capitation, they were really trying to pay for the value of better services and to incentivize efficiencies. But when I came to the department, I didn't see those innovations. The governor and I are also concerned about the increasing profit margins. For periods of time, the health plans were making more money on public programs than they were on the private programs. And what that told me was we weren't doing a good job negotiating those deals. The large amount of reserves, much of which was attributable to public programs, another concern. And also just the concern, frankly, with the amount and accessibility of information which is available about the contracting process and the contracting process itself. As I said, I recognized the positive aspects that managed care brought in terms of needed access to service for our enrollees. But I found overall there wasn't the accountability we need. And frankly, I thought we were leaving money on the table in our contracting and that we needed to do a much better job. But I want to be very clear as well. I didn't believe this, that we needed more accountability, that we weren't being as aggressive with our contracting, that we were leaving money on the table because I believed that there was any fraud going on. I didn't see that. I didn't see any deliberate wrongdoing, but rather I just believed we were not leveraging the very best deals we could. I think it's fair for all of you to ask me, say, okay, now, Cindy, you've heard these accusations about kind of things that were done in the past. And this was back when the GAMC program was up and running, which we're not dealing with anymore. What are you going to do about that, even though it's not happening right now? And those of you who know me know I do not hesitate to investigate wrongdoing. That's one of the reasons we instituted the Office of Inspector General in the department this past year. But in this case, at the same time that I first heard of the allegations, which Mr. Feinwalks referred to, was when I also became aware that federal authorities were investigating a number of these allegations. I can't say much about the scope of that investigation or the entities involved. I became aware of it because they were asking for cooperation from the department, and we are fully cooperating. But because I think it was a legitimate question to say, why aren't you investigating? The answer is because federal authorities are investigating this, and we're cooperating with them. Setting that aside, I believe that we really set about. Shortly after I became commissioner working with the governor, we wanted to get more accurate, complete information, make this process more open, and to make us a smarter purchaser of health care. So a couple of things we did pretty quickly last year. As many of you know, the governor issued an executive order on March 23rd to deal with disclosure and accountability in our managed care contracts. It required audits in the managed care plans by the Department of Commerce, created a comprehensive annual report on all the administrative expenses, because I agree, we need to dive into that more, premium revenues, and information on quality, access, and enrollment. It made data on the plans and contracts open to the full public disclosure via a new public website, which included all the public data that we could find and put it in one place. Now, can we do more? Can the legislature do more to create some accountability and transparency? Then the governor can in the executive order, yes, and we would support that. And I'll talk about that towards the end. But other people came up to me and said, Cindy, you've got to change these contracts. Well, I'm a lawyer, and I know after contracts are signed and negotiated, you just don't go and one party doesn't walk in and change them, even when you have questions about it. But what we did do was I approached the plans, and we negotiated voluntary caps on profits for the 2011 contracts. In early April, we reached a voluntary agreement with the 4 major health plans that for a one-time cap on 2011 earnings at 1% of revenue. And I want to thank the health plans for agreeing to those caps. Now, people say, why did you do it only for that year? Well, the reason we did it for that year is because we knew going forward we were going to change the way we did contracting. And Scott's going to talk a little bit more about that, but let me just open it up on the competitive, about why we decided to do competitive bidding. And I know competitive bidding is something that's been talked about by many of you on a bipartisan basis in the past. I guess the only thing I would say is we did it. We did it quickly, and we got dollars that helped to deal with the budget deficit last year. Now, one of the reasons I thought we needed competitive bidding was because I think Mr. Feinwalks talked about the fact that there wasn't enough risk in these contracts, and that was a concern I had. And I know I'm being simplistic here, but basically the way I saw it is we decided what to pay the health plans next year by looking about how much they charged us and how much we paid them for the last 3 years. And then we added medical inflation to that. Well, I look at that and say, where's the incentive to change? We had some small withholds, but not much. And I am all about the fact that we need to change incentives if we want to change behaviors. So rather than just doing rate setting a different way, we said, let's just put these contracts out for bid. And Scott, do you want to maybe say a few words about that, and then I can finish up?
Thank you, Commissioner. Members of the committee, my name is Scott Leitz. I'm the Assistant Commissioner for Healthcare at the Department of Human Services. And I want to reiterate Commissioner Jessen's thanks for the opportunity to talk a little bit about some of the efforts we've undertaken in this area. I also want to start by strongly reiterating the Commissioner's comments about the very serious immediate look that we took at our purchasing practices when we took office. As many of you know, in the Governor's budget last year, we did roll out a new approach to purchasing for our managed care products. Rather than purely doing rate setting, as the Commissioner just described, as we had done in the past, we moved rapidly to introduce a concept that, frankly, we were somewhat surprised had never actually been introduced in these programs before, and that is the concept of competitive bidding and the ability of plans to compete against each other for business in the public programs. It was an effort to bring market competition, to bring the best price and best quality for our enrollees. And we started this process in the Twin Cities area. And the reason we did that was that coverage for our 7-county metro area and reprocurement for those health plans was due up anyway.
Just your 15 minutes.
Thank you, Mr. Chair. And we won't dwell on this point, but I wanted to just drive down the point that we acted very rapidly to really change the way that we did our healthcare purchasing, I think for many of the reasons that have already been discussed today. We did go through that process, and at the end of this year issued contracts to plans, but I want to talk briefly about the results that we actually achieved on that. And I know this committee has heard this before, but I just want to reiterate that, as the Commissioner said, there were real savings that were actually accrued from this process. The contracts alone that we cut saved about $175 million to the state for the biennium through the mere introduction of competitive forces in this process. Not only does that help us in the short run, but we also believe it'll help to lower the cost curve moving into the future. And overall, when you combine that with some of the other reforms that we have, close to $250 million was saved of state money as a result of that process. Very briefly, Mr. Chair, one of the things that we've been going through right now, and I think I have testified in front of your committee about this already, we're going through the process of transitioning enrollees from the plans that they were in to the plans that were selected, because we did not select every plan that was available in every county. Federal law requires us in the metropolitan area to contract with at least 2 plans, and we did that in all of the counties in the 7-county metro. For 4 of the counties, there's 2 plans operating. And then in 3 of the counties where we had the most population and the most people moving, to ensure we had smooth transition of almost 80,000 people who were going to be changing plans, we did add a 3rd plan to ensure that continuity was able to be achieved. Mr. Chair, we're also planning to rigorously evaluate this process. We want to learn from this process so that we can do it better into the future. We think this was a good start. We think this proved to be very effective. But we want to ensure that we get better in the future on this as well. We also, as part of the competitive bidding process, I would say that's just one important strategy that we have right now in terms of overall managed care reforms that are projected to save the money I discussed. One of the things that I wanted to just touch very briefly on, Mr. Chair, is that we're also very focused in the Governor's executive order that the Commissioner referenced earlier on one of the elements that Mr. Feinwatz talked about, and that's bringing some additional level of audit to the data and information that is submitted by the health plans. So let me talk very briefly about that, Mr. Chair. As part of the Governor's executive order, the DHS is entering into an agreement with the Department of Commerce to conduct audits of the health plans. Commerce does already contract with a third-party outside auditor to conduct these audits, and these audits will begin in the late spring with filings that are submitted by the health plans for their 2011 operational year. So those filings are typically brought in April, and the audits of that information will be conducted at that time. These audits will focus on two primary areas. First and very importantly, we will be reconciling what is submitted under those financial statements and ensuring that that reconciles with what is submitted for rate development. That is something that has been lacking in the past, so we want to ensure that we're creating that tie between information that's coming from various sources. It's important that what plans are filing with regulators square with the data that's submitted for the development of rates for those public insurance programs. And this is particularly important for 2011 because, as the Commissioner mentioned, we reached a voluntary agreement with the health plans to cap profits for the final year of contracts that were negotiated previously at 1%. And so we want to make sure that that information is tying to the financials. And we will look aggressively at any discrepancies that we find. Secondly, one of the things that Mr. Feinwachs discussed was the fact that we previously did not have good allocation of administrative expenses across programs. And with the legislature's help last year, we passed a law to allow us to collect more detailed information on all of the public programs that we operate, especially on the administrative cost side. The audit will take a look at that information that's being collected and ensuring that that we fully understand how things are being allocated from an administrative expense perspective. We do not, as a public health insurance program, want to be paying more than our fair share of administrative expenses relative to the commercial market. Lastly, the last thing I'll say before turning it back to Commissioner Jessen is that we will be examining the encounter data that's submitted by the health plans. For the first time this year, and this is an important change that we're implementing, the data that is submitted to the plans will include price data. That's another of the elements that Mr. Feinwachs talked about. It's the inclusion of price information along with the other information around services that are provided. That will allow us to have a better sense of not only the types of services that are being provided, but the level of payment that's associated with those services, so that we're able to report back that information to you to fulfill the final element of the Governor's executive order, which is an annual comprehensive report on managed care, so that you have an understanding, a very, very clear and transparent understanding of how we're operating our programs. With that, I'll conclude and turn it back to Commissioner Jessen.
Thank you, Scott. Let me just say a few words about the UCare donation, since that came up. First of all, let me say, once again, thank you to UCare for doing this. I think it was the right thing to do, and it was unprecedented, and I want to acknowledge that. I certainly thought it was a donation. To be a repayment, wouldn't you think, you'd have to ask, someone have to ask for us. And I still remember that Monday morning meeting when I saw my calendar that Nancy Feldman had just pushed her way through my good assistant to say, no, I really have to talk with the commissioner. And they came to my office and they said, we're going to donate $30 million from our reserves to the state. That was on March 14th. So I certainly thought about it that way. I was actually out in Baltimore meeting with CMS about some other matters on the March 16th and 17th, so just later that week. And I remember telling CMS, I said, look, we got this donation, unprecedented in Minnesota. I want to tell you about it. We think it's a donation. We don't have to pay the federal share. We know you may disagree. If you do, let's sit down and talk about it. So we certainly, tried to be upfront about it, but also just appreciate, them stepping forward. We tried to notify folks about that. I know that, letters went to both of you as chairs and to the minority leads, and we've certainly been following up, documenting this with CMS. But so just let me maybe say a few words in conclusion, if I may. The changes that we have made in the past year, I believe, really constitute a great step forward in reforming our purchasing and increasing our openness and accountability at the department. I think we've made a fundamental shift in the way we do business with the health plans. But we're not done. We're continuing the efforts this year by evaluating our competitive bidding process, looking at ways we can improve it in the future, and working with the help of counties and providers to develop improved health care delivery systems that will increase the quality and decrease the cost of care along the line of trying to create that third way. Looking at where we can use competitive bidding in the process, where there's enough competition. I think few people understand any more than, let me put it this way. Few understand the fiscal pressures of our current budget predicament and the effect on human services delivery better than those of us, especially in the leadership team at the Department of Human Services. But I know that many of you around that table join us in understanding both the complexity and the importance of the fiscal pressures that are need to provide critical services. But speaking for the department, I'll say that we certainly understand that today every public dollar is more precious than ever, and that in order to better serve the people of Minnesota, we need to be able to continue to do more with less. And that includes taking a hard look at how we pay for health care. I understand just in my conversations with many of you and with others that there may be interest in examining ways to bring more accountability and more transparency to this process. The governor did what he could in the executive order. I think there may be additional ways, and we strongly support those concepts. Concepts like, independent audits, certainly. Making sure that the state and plans can't use the same actuaries. We've started putting that in our contracts, but having that a matter of law makes a lot of sense. And we also think that we need to do whatever we can to provide quick access to the encounter and pricing data, making sure it's both usable and accurate. So those are things that we would look forward to working with the legislature and others about. So once again, thanks for hearing us out, and we'll field questions later.
Thank you, Commissioner. Mr. Lights. And you finished early, so if the health plans like to come down for your 30 minutes, and I don't know who all you're going to testify, you're free to go beyond the list you've submitted if you'd like to do that in your testimony. So, welcome to the committee, and introduce yourselves. And
Great.
thank you for coming.
Chairman Abler, Chairman Gottwald, members of the committee, my name is Julie Bruner. I'm the Executive Director of the Minnesota Council of Health Plans. With me today is Jeff Barsh, Vice President of Public Policy and Government Relations with Medica Health Plan. Medica is one of 5 members of the council that contract with the Department of Human Services to provide coverage and access for Minnesotans enrolled in Minnesota health care programs. We were asked today to talk to you, share some facts about accountability and transparency of the HMOs in the administration of the Medicaid program. Last year on February 8th we were in, and I think we overwhelmed you with a box of information trying to let you know how much information we really supply, but we're not going to do that again. But what Jeff is going to do is to walk you through some of the high points and highlights around areas that we are reporting on a regular basis. We want to focus on a few of those areas, and as I said, Jeff will talk you through those, and then we'll look forward to an opportunity to answer questions later.
Welcome to the committee.
Thank you, Chairman Abel and Chairman Gottwald. Again, for the record, my name is Jeff Barsh. I represent Medica. As Julie mentioned, I'm just going to talk about a couple highlights here. I think the department gave a nice overview, and then I think we'll be available for questions if members of the committee have them afterwards. The first thing I'd like to talk about is the fact that the HMOs in Minnesota, our financial information is independently audited, and that's done annually. That's a requirement in state law. Okay, that's a fact. State law requires that our financial information is independently audited. And there's a raft load of statute that describes the format in which the certified public accountant has to be qualified, attest to their independence, regulations that spell out whether or not they can work with us for other lines of business in order to make that happen. In addition to the annual independent audits that we're required to submit, we are audited by the Department of Commerce, the Minnesota Department of Health, the Minnesota Department of Human Services, the Center for Medicare and Medicaid Services, as well as the Minnesota Attorney General has the ability to audit us as nonprofits. I just again like to state that all for the record. We are independently audited, and we are audited by a number of state and federal agencies. Those are facts. The second thing I'd like to talk about is the fact, as Mr. Lights discussed, the HMOs are required to submit granular level encounter data on all of our Medicaid and other state public programs members to the Department of Human Services. State law and our contracts with the Department of Human Services spell out in great detail the manner in which we are required to submit that information. The guidance for how we are to submit that is also spelled out in great detail. That's publicly available on the Department of Human Services website. The information that we submit in the encounter data spells out very clearly for each of our Medicaid or state public program members who the member was, what the service was, where the service took place, who the provider was, how much we paid for that service, if it was a prescription drug, what the drug was, and where it was filled. Again, that information is submitted to the Department of Human Services monthly, is spelled out in our contracts and spelled out in state law. The last thing, or the third thing I'd like to talk about is just to remind the committee again that HMOs, as a requirement of our licensure, are required to participate in our state public programs. When the state expanded the PMAP program statewide in 1996, I believe, that requirement went into law. So for every HMO that's licensed in the state, even if we want to operate only individual or group insurance, we have to participate with the state for our state public programs. Even in the counties where the competitive bidding process has now got into place, we are required to submit a bid to participate in these programs in those counties. Last year, this committee and I think a Senate committee discussed whether or not to remove that requirement that we participate in the programs. You didn't act. But that requirement is still in place. What that means is we are bound by the rules set by the legislature and the Department of Human Services to participate in these programs, not just for these programs, but for our licensure in the state. Mr. Chairman, the 2008 Legislative Auditor's Report was mentioned earlier. I agree it's a good report. It's a good read. In reaction to that report, in 2008, the legislature passed a law in response to that. Spelled out new requirements for how managed care plans and county-based purchasing plans report our administrative expenses, how we treat investment income, how to satisfy the information that we submit for quality, and that law also limited what the Department of Human Services could pay us under our contracts for administrative expenses. Then in 2009, the legislature passed a law requiring reporting of specific provider reimbursement information and required DHS to submit a report based on that information to the legislature. In 2009 was also when the state updated the independent auditing laws that are in place. That also passed the legislature in 2009. In 2010, the legislature passed a law further defining how administrative expenses for HMOs, not just for public programs, but in general, report our administrative expenses so that there's consistency in how those are reported across public programs. And then finally, as Mr. Lights talked about, there was the executive order and the legislation passed in 2011 that again talks about how to manage care and county-based purchasing plans, submit information on administrative expenses, non-administrative expenses, encounter data, and some other information. Mr. Chairman, we comply with all these laws. In addition to the laws that were passed, Commissioner Jessen discussed the competitive bidding proposal last year. I can tell you as a health plan that lost a bid in 6 of 7 counties, that was a real change, one that quite frankly our organization wasn't thrilled with. But as these programs move forward and as we had the discussion about competitive bidding last year, Mr. Chairman, I told you that these are the Department of Human Services programs. They're the state's programs for the legislature and the department to manage. And you can change those programs or alter the contracting arrangement in the manner that you think makes the best sense for the state of Minnesota. We think we're good partners for the state. We think we've been good partners for the state. We'd like to continue to be good partners for the state. But we do comply with the laws that are set forward by all of you. We're happy to do so moving forward. We're happy to answer any questions that this legislature or other people might have about information that should be reported to the department that is not being, and how that information that's getting to the department can be made available to all of you to make your decisions. Mr. Chairman, with that, I think I'll end my comments. And again, thanks for the time, and I'd be happy to answer questions when we get to that point.
Ms. Bruner, do you want to continue?
No.
Oh, that's it. Okay. Well, thank you. And you have more time left, obviously, if you wanted to use it. Well, I think what we'll do now is assemble the 5 witnesses. If they would, Commissioner, you're comfortable sitting at the table, and with Mr. Lights and Mr. Feinwalks, if you want to come down. I didn't give our pages heads up about this, but we'll need 3 more chairs. There's some up here that aren't being used currently, if you want to come steal a couple of those. And so we'll move into some question time here, and I think we'll just continue our normal committee format and take a break at 2:15, and then I think we'll reconvene at 2:30, like we would normally do. We'll try to make that a time certain, just so people can, stretch their legs and so on. And while they're getting set up, I'll just offer my an overview of this. I see three different topics coming out of this. I've been discussing transparency issues for at least 4 years, if not longer, and it's hard to not do that when you're sitting at these chairs up here. So like Representative Gottwald said, none of this is new. And I've argued with the department about how they set rates, and is it cost plus, and Ms. Peed, and all those, and she remembers those discussions, I'm sure. Senator Bergman was part of this, and it goes way back. But to summarize, what I see is the three salient topics that have been brought forward by this and past discussions. One is the first thing about this rate setting, the GA piece and the medical assistance part, and which we had some testimony about that in the beginning. And not much reaction beyond that so far. And then the second part has to do with transparency and audits, and how do we know what's going on, and is that a reliable thing, that pot of discussion. And the third thing is reserves, and what's an appropriate amount of reserves for plans to have, and are they indeed at risk or not. To me, those are the three topics that I'm taking away from this. Not to tell you what else you can't take away, but that's just how I see it. And so since the panel is assembled, I'll take the first question. And about my question about the auditing. And the department is changing a bit, which I appreciate. And I think Mr. Feinwachs had some good points about, is there entanglement or not? And I don't know that. But we always wonder, what are we getting for our $7 billion of biennium? And federal money is ours, too. So can a couple of you, you can just comment as you like, about the audits. I just have a sense in my mind that the past audits weren't that worthwhile, and we didn't really learn a lot from that. And even though you submit boxes of information, Mr. Barch, I've heard that, and I believe it, and you gave us a box full, and it was a lot. I still have the box. Could have put it in pink ribbon today for the holiday. But has that been a worthwhile experience? Do the plans learn something? Does the department learn anything from that, Mr. Leitz? Do you find that you can't wait to read it and see what's new? And so is the new system that you're putting forward, is Commerce the place to do it? Should it be the state auditor doing it, or some third party we don't even know who they are? Can you comment about that, please? And I don't know who wants to go first. I can give all three groups a chance to comment.
Mr. Chair, Scott Leitz from the department. I'll start with that. I think stepping back from our perspective, we felt that the audits that were being conducted provided information around the solvency levels of plans and other things that are important for us to know from a consumer perspective, a protection perspective. But the reason that the governor's executive order directed us in the direction that it did, which was really more around helping us to better understand whether the dollars were tying back to, whether the financial statements were tying back to what the rate setting process had looked like, what the how we're allocating administrative expenses within those programs. Those were questions that weren't necessarily being answered by audits that had been occurring in the past. I think the health plans are audited on a lot of stuff. But those were salient questions that we wanted to know the answers to. We were hearing questions from this body as well as from others in the community around this issue. I think that's the direction. That's why we wanted to go the direction that we did in the executive order. And then the third thing I would say related to that is, and this relates back to the encounter data piece of this, was to try for us to more fully maximize the use of that information to be able to get at a much more granular level and understanding where the dollars are going. And I think that the way that we part of the problem, I think, with the process that has occurred up to this point has been we get all this information. I may love it because I'm a kind of a nerd and like to wonk out on these things. But unless you're really into it, you don't understand necessarily what it means. And I think that's very much the point of the governor's final part of the executive order is now tell us what this all means. Produce an annual report that reports back to the legislature, reports back to stakeholders in the community where the dollars are going in the system, what changes might be necessary, what do the contracts look like, what does that process look like this year, what do you expect to see in the coming year. So I think that is the approach that we've taken since coming in, has been to try to build on what's already there, but add to the pieces that we know people have been asking questions about.
Thanks. Mr. Feinwachs, do you want to go? Ms. Bruner, you want to go? Yeah, then Mr. Feinwachs.
Chairman Abler and members, a couple of things. First of all, the department or the council, the plans have supported the direction that the department has taken under Commissioner Jessen. Being smarter purchasers of health care is something that the plans have been engaged in the commercial side of their business for years. And so having the state move into that, it seems absolutely reasonable, particularly in times of financial stress. One of the things that we've asked at plan level for years is, you saw that box last year, we kept saying, who looks at this stuff? Is anybody examining all these reports? And so the idea that the department is going to be looking at what's useful, looking at it in different ways, perhaps changing what they ask for so that we don't submit the same information to the Department of Health, the Department of Human Services, and the Department of Commerce. All of the things that have happened to the plans in terms of reporting in the last decade have been additive. It's more and more and more. And all that does is push up administrative costs, which pushes up the cost of health care. So I think the opportunity to pause, take a look at looking at auditing in a different way, reporting in a different way, alignment between the three state agencies, which I understand is seriously under consideration right now. I think it's a great opportunity, and we would support that. We don't object to more audits because the plans are so audited right now. I mean, come on in. They have rooms set aside. There are auditors in the health plans every day of the year, one or two different, a private auditor, CMS, the Department of Commerce, the Department of Health, or the DHS Michigan firm. There's somebody auditing in a health plan every day. So the idea that we would all have an opportunity to get smarter about doing that, we would support that. But at the same time, I would urge the department, and I've had conversations with the department about this, and I've talked about it in front of this committee before, is let's get smarter about the information that we're asking. I mean, if you submit the same pieces of data to three state agencies, but it's in slightly different formats, that doesn't make any sense at all. And I think that this administration is looking at how to do that kind of alignment.
And I know the MMB project is underway and has had some success about consolidating some of those. And I wonder who has to pay all the coffee for those auditors. Mr. Feinwach, do you want to comment, please?
Chairman Abler, members, yes. My comments would be basically in two areas. First of all, I didn't finish my PowerPoint because of time, but for those of you who have it or have the last slide, and I'm going from memory, so don't hold me to it. The last slide of my presentation was, in fact, an email from someone at the Council of Health Plans. Oh, thank you. Which I believe said something to the effect that what Feinwachs is talking about is that nobody actually looks at every receipt and the underlying information, and he's right about that. And in fact, that's the problem here. The kinds of audits that we do here are largely based on summary documents which are really incapable of audit. They are summaries prepared by the people who are being audited, and you can't really dig past the summary. Sort of like if the IRS audited you and you gave them another copy of your tax return and said, there you go. Well, typically what they want to see is canceled checks and credit card receipts and the source documentation that led you to the conclusions and the numeric values that you're offering up in the summary documents or the tax returns. And that appears to be what we're lacking here. And I agree with Ms. Bruner. I think a great deal of what we've saddled the plans with in terms of reporting requirements is not useful and a waste of time. What I'm proposing is true independent third-party audits, which is audits conducted by people who are not state agencies, who accept neither money from plans nor providers, and who do this kind of work solely for government and enforcement agencies, and basically have no reason to give you anything other than the straight scoop.
Thank you. Other questions now, and I'd like this is, I know this is not a partisan matter. I have three on my side of the aisle with questions. I'd rather go back and forth, so if Representative Huntley would be after, why don't you go first, then I'll go with Representative Gruenhagen.
I have a couple of questions, I think, for either Scott Lights or Commissioner Jessen, Mr. Chair. And one of the things I'm most interested in, and I don't think we ever get to it, is do we really measure the health outcomes of any of these people? Or do we just look at how much dollars we spent and how much went into administration and how much went to some provider? Do we actually get data on whether we're improving the health of these people?
Commissioner?
Mr. Chair, Representative Huntley, I'm so glad you asked that question, because when we were talking about these financial audits, I wanted to jump in and say, can we talk about audits about outcomes and how we're doing? And one of the good things I think we're doing at the department and have done, I think, was last year the first year, Scott? I think just last year was the first year. Is we've contracted with Minnesota Community Measurement to come in and help us and look at our data and to say, okay, let's compare how we're doing on these key factors. And we'll look at different ones, different years, and compare how our public program enrollees are doing, and not just, to some mythical standard, but versus the private enrollees, as well as where we think they should be. So how many of our kids on public programs are getting vaccinated? How many of the people in our public enrollees getting optimal diabetes care? And we can do that now, actually, not just across the board, but by clinics. We can go in and be able to say, this clinic is doing, like I just gave an award recently to, I think it was the Litchfield Clinic, exceptional award on a number, treating, for meeting these quality measures for our public enrollees. So we are really starting to make a big effort towards that. I think in this third way I've talked about contracting with providers and creating, getting them to be responsible for the health outcomes of the population they serve, as well as if they reach those health outcomes, being able to share in any efficiencies and any cost savings also really kind of goes to that issue. Yes, we need to look at the dollars, but we also need to say, are we getting what we're paying for?
Representative Huntley, do you have two questions?
Mr. Chair, then I have another question. Our rates that we pay the health plans, are those certified every year by CMS?
Mr. Chair, Representative Huntley, yes.
So, Mr. Chair and Assistant Commissioner Lights, that means that they have approved the rates that we're paying to the health plans. And I don't want to get in an argument about actuarial soundness, but they approve those rates.
Mr. Chair, Representative Huntley, yes.
Okay. Representative Huntley.
And thank you. And Mr. Chair, I'll have a comment at the end.
Okay. We'll put you like at 4 o'clock or something. Representative Gruenhagen.
Thank you, Mr. Chair. My question is, I got several questions and just appreciate responses from the three different groups here. I spent about half my legislative life last year on this issue, and it's awful slippery, it seems. But and I also authored several pieces of legislation to try to get at some of the questions that are here too. But one of the things that concerned me that I learned through this, I was given a graph from one of the plans, and it showed that between 1998 and 2010, funding for the PMAP program went up by 105%. So that's about an 8 to 9% increase per year. But when you looked at the provider reimbursement rates, they stayed flat, and in case of specialists, they actually went down in 2009 and 2010. Now, the explanation that I got from the HMOs is that while our enrollment increased, and that's why the provider reimbursement stayed flat. Of course, it's a big concern of mine because obviously when providers are losing money on these reimbursement rates, they try to make it up in other areas, especially private insurance, and ultimately that drives their rates up for the rest of us that have private insurance. So one additional observation, I met with some county health workers in my district, and they could remember that prior to the HMO plans administering the PMAP program, when it came straight from the state, they used to get increases on their services on a pretty regular basis. But now they haven't seen increases for years on their reimbursement rate. So my question is, since funding has gone up 105%, and yet providers' reimbursement has stayed flat for over 10 years, is it valid to say that the increase in enrollment has actually produced that result, or should providers be seeing some type of increase on their reimbursement? And I guess I'll start with Mr. Feinwalk, and I'd like all three areas to respond.
Mr. Feinwalks.
Mr. Chair, Representative Gruenhagen, I think you've touched upon an interesting issue. There appears to be no parity between increases in terms of money poured into the program and what the providers actually receive. The question that you're asking, or at least that I perceive you to be asking, is really a critical question. What's the biggest cost driver in the healthcare system? And in order to answer that question, we have to take a long, hard look at the middleman or broker to see what costs they're adding and what value, if any, they're adding. Because it's quite possible that, in fact, the HMOs are one of the largest cost drivers in the system.
Commissioner, do you want to? Okay. Go ahead, Commissioner.
Mr. Chair, Representative, a couple of things. Well, I'm all for looking at cost drivers, I must say. I do think when we look at those overall numbers, we do have to also look at enrollment data. And, you know, you got the chart from the plan, so I'm not sure just what you're looking at, but let me just give you a couple of numbers I think that are important. You know, I just stepped back, for example, and looked at the enrollment in our MA for Families and Kids program just since the recession. We have over 100,000 more people on that program since 2008. Just astonishing. But here's one thing that I think shed some light on this. I just looked at this national study. It was a national study that looked at costs per enrollee in a Medicaid program. And so they basically were taking out the enrollment ups and downs and just say, let's look at this across a number of years. And so I, of course, dive in and say, where's Minnesota? Because they had basically a national average cost per enrollee. And now this isn't just health plans, so this is across all our programs. And in Minnesota, and I'm doing this by memory, but I'm pretty sure my numbers are right, between 2004 and 2009, the national average increase per enrollee was 2.3%. Minnesota's cost per enrollee was 1.7%. So we are actually below the national average, and I think that is, frankly, because we have kept, I think often we do need to do more for providers. So I'm very sympathetic to that. You know, actually, during the period of time 98 to 2004, we were twice the national average. So we were significantly above the national average. But most recently, during the period of time you're talking about, we've been less when you look at it on a per enrollee. But I do agree that we need to look at this, these provider payment issues. And that's one of the reasons that we are very happy that just starting last year, in the 2011 contract year, we're getting the data from the plans, the encounter, and price data so that we can analyze it and hopefully put that in this transparency report Assistant Commissioner Lights referred to so we can start to track how much we'll do it in a summary form. We don't want to be, anti-competitive here since I'm promoting competition. But we'll state, okay, how much are the plans, paying this category of provider? Are there big differences between plans? How is that changing across the years? That is the sort of information we very much want to get at.
Mr. Barch or Ms. Bruner?
Mr. Chairman, Representative Gruenhagen, I think the first thing to think about when you're asking your question is that the payments to the health plans are a payment for an aggregate for all of the services for all of the members. So it encapsulates both utilization, enrollment, and the price itself. When you're looking at the specific fee paid to provider for a specific service, that's just one fee for one service for one provider. So the fee schedule has stayed relatively the same, but both the enrollment and the utilization has gone up dramatically. And the health plans, independently audited financial statements, reconcile that. You can also look at what little claims information is submitted from providers. The hospitals, I'll give them credit, they're one of the only provider organizations. They submit a wealth of information in their hospital annual reports. And if you just look at the revenue that they're reporting from the prepaid medical assistance programs over a period of time, you'll see those rates increase over a period of time, even though the specific fee schedule itself has not increased. Again, the factors are both enrollment and utilization.
Representative Gruenhagen, one more question, then there'll be time late after the break to get another one in later.
Okay, next question is on the reserves. Okay, Mr. Feinwalk's position is they're excessive, and I don't want to put words into your mouth, but when I talk to the plans, they say they're mandated by law to provide these services, and if there's an interruption or decrease in funding from the state in any way, they need reserves to fall back on. So because they're mandated by law, they have to have these reserves, and I guess I just like the same type of response. Mr. Feinwalk, what's your position on the mandated reserves?
Mr. Feinwalk.
Mr. Chair, Representative Gruenhagen, as we discussed earlier, these arrangements, these contracts, have no real risk associated with them. And so the only theoretical risk is that the state of Minnesota will cease to exist from one year to the next before you can get all your money back. So now,
Possibility.
given the current environment, Mr. Chairman, I agree with you that now perhaps more than ever before, it's a possibility, but I think we can all agree, or at least hope, that it's an extremely remote possibility. And therefore, the amount of the reserves do indeed seem excessive, given the nature of the actual risk.
I'd like the department and the...
Oh, they're going to. Mr. Bartsch, do you want to comment, or which of you
Do you
two?
guys have a comment?
Commissioner.
Mr. Chair, Representative Gruenhagen, this is one of those moments where I first have to say I'm not the Commissioner of Commerce. And that is really kind of in the Commissioner of Commerce's area to look at the appropriateness and level of health plan reserves. I would say, though, that, I mean, from my perspective as the Commissioner of Human Services, I hope you heard me saying this during my testimony, I want to do everything I can to negotiate better deals so that we aren't increasing their reserves more with public dollars than they are with private dollars, which I found to be very troubling.
And Commissioner, I just thought of a kind of a rule we can make up here. There's like a lot of health plan people, for instance, and so if one of you wanted to phone a friend to answer instead of you, that would be fine. There's only one Mr. Feinwalk, so I don't think you're kind of here. But like if the Commissioner just said she couldn't answer the question about reserves, after the break I'd like to hear from, maybe somebody from Commerce can come and tell us that question. And that somebody, maybe if they're listening, can get somebody here for the 2:30 hour to have that be one of the first questions. Mr. Bartsch, do you want to go on there? Thank you.
Mr. Chairman, Representative Gruenhagen, health plans and all insurance companies, whether it's property, casual, health, are required to carry reserves. The reason is you're accepting risk for the entity that signs a contract with you, and regulators want to make sure that you have the financial stability to actually cover the risk that you're accepting. We're required to have reserves, but reserves are a commonplace situation for any nonprofit organization, local units of government. Some of us hope they would have been for the state of Minnesota or the federal government. That's not the case. But our reserves are there to protect our consumers, whether they are a state public program consumer or a commercially insured consumer, someone who buys individual insurance or group insurance. So the reserves for our organization protect the risk associated with all lines of business, not just one line of business. Our reserves are not excessive. I don't think that an evaluation of our reserves would be excessive if you looked at them as a measure of risk-based capital, which is how they're measured by the Department of Commerce, or if you applied what used to be the state's measure of appropriate reserves. They used to measure reserves on a months of expense basis. So HMOs were required to carry between 1 but not more than 3 months of expense. I think if you look at all the HMOs, at least with their 2010 financial statements, we're all within that corridor that used to exist. So no, I don't believe the HMOs or the insurance companies in this state are excessively reserved.
Thank you. Well, you can follow up later. Representative Liebling? Oh, did you just want to comment about that? Okay.
Yeah, just Mr. Chair, I just got 1.5 more questions, so whenever you can fit me in.
Yeah, on the list we have Liebling, McDonald, Haas, Gottwald, Lane, Quam, Mack, Barrett, and Grunhagen. There's plenty of time. We put a lot aside for this, so Representative Liebling.
Thank you, Mr. Chair. And I'd like to go back to the issue about the $30 million donation from UCare. And, just leaving aside, just that was a donation. Obviously, they weren't obligated to make that repayment. But it does bring us back to the underlying question that Mr. Feinwachs talked about, which is that and I'm looking at this letter that he gave us from UCare to Senator Hann, and I do kind of vaguely remember receiving this myself. We were all very happy that there was some extra money for the budget. But it does bring us to the question that Mr. Feinwachs raised about if indeed we had essentially overpaid, and I understand that was a contract, and you can't undo your contracts. But we'd essentially overpaid the plans because we were paying them for our GAMC program, which of course cost a lot more money. And then that program went away. It says in this letter that historically DHS rates set for general assistance medical care resulted in health plan losses which were offset by higher medical assistance payments. When GAMC moved out of managed care in mid-year 2010, medical assistance rates were not lowered to reflect this overpayment. So I assume that affected not just UCare. UCare is telling us about it in this letter. It must have affected the other plans. And I'm just wondering, maybe they just kept it that year. Those who didn't volunteer it back didn't give it back to us. But I'm wondering if that's been accounted for going forward. And also, I guess I'd like to know what the plans have to say about that, other than UCare. And also, how was that number? I don't know if there's anybody from UCare here. Maybe Ms. Bruner knows. But, how that particular number was arrived at. Is that... does that number represent, I'm just curious about if we got $30 million from them, should we have gotten, is that the right number? And should we have gotten something from the other plans on a voluntary basis, perhaps? But if not, going forward, have we made that adjustment to account for the lower costs or to account for the fact that program isn't there anymore?
Good question. Ms. Bruner?
Mr. Chairman, Representative Liebling, I can't comment on the decision or the calculation that UCare went through. That was not something that was done through the council. The health plans didn't talk with each other about it. I do believe that Agita Wooster is here, and she may be able to give you some additional details.
This is part of the Phone a Friend feature. Welcome, Ms. Wooster, to the committee.
I'm Gita Wooster, UCare's Senior Vice President of Public Affairs and Marketing. Mr. Chairman, members of the committee, I do want to reference that there were several points in that letter. So when I talk about how we determined the $30 million, it wasn't just our reference to the fact that the GAMC program was closed down. We did talk about the difference in the patient population that was in the program, the fact that we did a lot with different initiatives for medical costs and administrative costs. But what we simply did was look at what the expected target was for the net income for the program under the DHS contract, and then the amount of money over that our health plan made, and the $30 million was the result of that. So it was very simple math in that perspective.
Representative Liebling, do you want to follow up?
Okay, thank you,
Or ask more
Mr. Chair.
people, you can-
Well, yeah, I guess, thank you, and I guess my question then is, more to going to the other plans, whether they didn't think, too, that perhaps they had netted extra money for that year and should perhaps offer some of it back. I mean, surely the other plans were aware that UCare had done this, and yet nobody jumped up and said, me too, me too. And then I guess I'd like to know going forward whether this is going to be accounted for in some way.
Representative Liebling, the room is full of people from different plans, so if you want me to invite one down, I'll be happy to invite one. Take your pick, or do you want Mr. Barch to go?
That was my
Okay.
thinking. Maybe he'd like to phone some friends.
Okay, there. He wants to get away.
Mr. Chairman, Representative Liebling, I can only answer for Medica. I can't answer for the other health plans on this, but no, Medica did not feel at the time UCare made their contribution to the state that our earnings from our public programs warranted us giving a donation to the state. I think it's just as simple as that. They made that decision independently on their own, and the reasons for that are theirs.
Representative Liebling.
Well, thank you, Mr. Chair. And I guess, Mr. Barsh, then what they're saying in this letter about the fact that the GAMC had historically resulted in losses that were offset by medical assistance payments. Are you saying that that's not the case?
Mr. Chairman, Representative Liebling, no, not at all. I think the fact that no health plan, I think, ever made a positive margin off of the general assistance medical care program is not only common knowledge, but it's been discussed in this legislature numerous times. And the legislative auditor in the report in 2008 very clearly demonstrated that there is no margin attached to the rates that the state produces for general assistance medical care, but they do attach a margin for the medical assistance in Minnesota care program. So, no, I think everyone's known that. I think when the general assistance medical care program went away, it's our belief that the department did adjust the rates accordingly and move forward. UCare had a different interpretation of that.
Representative Liebling.
Thank you, Mr. Chair, and I won't belabor it, but I guess I'd just like to ask the department then to respond to that. Was there an adjustment and going forward from there, given that this loss leader was removed?
Mr. Lights. You want to phone a friend?
Mr. Chair, Representative Liebling, without getting too into the weeds on this, essentially the department, as I understand it, prior to the competitive bidding world, when we were doing rate setting and GAMC existed as a program, there is a requirement under federal law that you actually base federally matched program dollars, the rates that you set for those programs, on the costs and populations of those programs. And so my understanding is that the rates that were set for GAMC, traditionally being only a state-only program, were low. And I think it is agreed by everybody that they were likely below cost. But that's a separate issue from the PMAP rates, which are really set on the costs of the medical assistance program and the enrolled population for that program. That's my understanding of how that's been dealt with in the past.
Representative Liebling, are you?
All right, well, Mr. Chair, well, I guess I'm hearing two different things, and I'm hearing Mr. Lights say something that's very different than what UCare told us in this letter. And I, from what I understand, that's how it's supposed to be done. But the question is whether that's how it was actually being done. So I guess I'll leave it at that.
I'll call Mr. Fine. Well, I'm going to call Mr. Feinwalks. He wants to say something. Let me say something else. Now, I'm recognizing that the administration being representative in DHS now is not the administration who was then, but Mr. Lights was in the Department of Health and has some knowledge of this anyway, but it wasn't, or children's, and then children's, whatever, you've been everywhere. But so some of the questions I know are beyond the scope of the witnesses, but if you want to know about rates, we can actually have discussions about those. There's adequate staff that DHS, that is still working there, that did some of this stuff. If we want to drag Mr. Hoffman over some other day or talk about that. Oh, okay, anyway, he's busy today. But anyway, Mr. Feinwalks.
Mr. Chairman, thank you. Mr. Chair, members, I know that that the panel here is supposed to provide answers, but I want to leave you with a question to contemplate. If everyone agrees that the General Assistance Medical Care Program is being subsidized with a higher Medicaid rate, the real question is, do we all agree the federal government knew that this was happening? Because that appears to be the question.
Well, thank you. I think this is a good time for a break. I do want to acknowledge a couple, just a couple of guests in the audience. Well, we're going to, what?
Mr. Chair?
Yes.
Would you consider perhaps just segueing right into the next meeting since we're all seated here ready to go so we can just continue on?
Well, we announced that we're going to take a break at halftime. So
I realize that. I'm just asking if you'd consider that.
Yeah, I'm not doing it. So. I think people need a break. But let me just acknowledge Representative Bunn is in the audience. Mr. Nobles is here. I want to tell my mom Happy Valentine's Day. Pretty good. And I'm about to yield the gavel to Representative Gottwald, and we'll be reconvening. Come back at 2:30, and so we're in recess.